I'm here at the annual American Society of Hematology meeting in New Orleans. It's an exciting meeting for everybody in the myeloma field. There's a lot of new data that is being presented, both in terms of new therapies that are evolving for this disease, as well as results from large phase 3 trials. We are certainly going to be hearing the results from the large phase 3 trial that was done by the French group, comparing the combination of melphalan, prednisone, thalidomide, which has been the workhorse for the elderly patient with multiple myeloma. Comparing that particular regimen to the combination of lenalidomide, dexamethasone, again given for either a definite period of 18 months or indefinitely until the myeloma comes back. Now, this is a very exciting trial for several reasons. Clearly, this is one of the first trials that is being done in the phase 3 setting in the older patient population, trying to see if we can get good outcomes with a regimen that does not include melphalan. It also addresses a very important question in the field as to what is the optimum duration of therapy. Right now, none of the clinical trials so far have really addressed the question as to whether it should be given for a year, 2 years, 3 years. This trial is looking at giving the Revlimid and the dexamethasone for 18 months versus giving that combination indefinitely until progression. So I think the data is going to be really exciting, and it's going to be presented by Dr. Facon at the plenary session. Now, there's also a lot of interesting data with the new molecules that are being tested. Now, broadly, the new drugs, you can look at it as existing drugs being used in a different way, variations of the existing drugs, and drugs which are totally new in terms of the class of drugs that are being used. So an example would be the MLN9708, which is an oral proteasome inhibitor, which is the first oral proteasome inhibitor to be evaluated in the clinic. Now, we all know in the field, proteasome inhibitors have become an integral part of the therapy of multiple myeloma. And to be able to give that class of drug orally is certainly an improvement in the therapies that we can offer for our patients. Now, the results so far, we've seen the results from the past two meetings. There's studies being presented at this meeting as well, and again building on the wealth of knowledge in terms of how we use this drug in this disease. Now, there are new classes of drugs that are being used, especially the monoclonal antibodies, which is extremely exciting because that is a class of drug that has found a lot of success in other diseases like lymphoma. And it's been a long time coming for myeloma, and the results that are being presented looking at the monoclonal antibody against CD38 is certainly exciting. We already saw a glimpse of that at the past ASCO meeting, where the results from daratumumab was presented, and the results from the new drug, the Sanofi anti-CD38 antibody, which I'm hopeful will be equally exciting. Then there are multiple posters and oral abstracts that are being presented on new classes of drugs, varying from the cyclin-dependent kinase inhibitors, the kinesin spindle inhibitors. There's this various signal pathway inhibitors as well. Also very exciting is the genomic aspect of multiple myeloma. We have always suspected that this disease is very heterogeneous. And I think increasingly the data that is being presented confirms this fact at a genomic level. The data from multiple groups have looked at various genomic studies, looking at the cutting edge techniques, again showing that there's multiple subclones of myeloma cells in patients with this disease. And also important is the fact that this is not something that just starts when they get symptomatic disease, but starts right away in the beginning at the very early stages of monoclonic gammopathy of undetermined significance, as well as smoldering myeloma. And it's a very fascinating story about how this clone evolves, or the different clones compete with each other and evolve during the evolution of the disease, and how these clones behave differently when faced with a particular treatment, and how they evolve during the various stages of therapy, including development of resistance to particular therapies. So I think we are making dramatic progress, not only in terms of the biology of the disease, which will eventually inform us how best we are going to treat them, but at the same time we are also developing a lot more tools to treat the disease. And finally, I want to leave with the note about how we are starting to measure this disease. So there's a lot of data on looking at minimal residual disease, a concept that is been going around for a long time and has been used in the clinic for leukemias, but I think it's become finally the prime time for MRD testing in myeloma as well. So there's exciting data from the Spanish group looking at the flow cytometry as a way of detecting minimal residual disease in this disease. And I think a year or two from now, I think all of us will be using that in the clinic, and it will be an integral part of our clinical care and definitely part of every clinical trial we do. So exciting times are ahead.